Can I just ask, who is Paige Clunan and who is Barty?
Hi, I'm the medical student who's rotating. Nice
Hi,
to meet you.
Paige. How are you? And Barty?
Um, I'm the resident in second year at Almast who's also rotating in cardiology, Dr.
Excellent.
Pass. Good
Thank
morning.
you. Just wanted to be sure we didn't have some people who are spoofing us here. Okay, one moment. I'll share my screen. All right. Let's see. I'll give it one more minute and then we'll get going. Guess we'll just move forward. All right. So this patient has end-stage renal disease, and this is the electrocardiogram. And so my question is, what is the diagnosis, and how would we treat this? So why don't we ask Dr. Katoki what she thinks?
Good morning, Dr. Pass.
Good morning.
So I'm looking at the rhythm strip and
Yeah, it's end-stage renal disease.
right, and I see a P wave and what appears to be Q. I guess that's probably not a positive wave. It's a QS complex. And followed by upright T waves. And it seems that the P waves
Patient is in end-stage renal disease. I'll say it a third time to help inform your consideration of this tracing.
Stage.
What happens when your kidneys don't work so well? To your electrolytes. Why do we dialyze people? What is one of the bigger concerns?
Okay, I think the T waves appear to be very upright. So and the QRS also the QS appears to be prolonged. So is this an EKG showing hyperkalemia?
Yes, that's correct. This is an ECG showing advanced hyperkalemia. We'll go over the findings of that in a moment. But if you saw this and as you were looking at the tracing, the nurse hands you the blood gas and the potassium is, let's say, 7.5, what would you do for this patient?
I would give the patient calcium. And
What
then
else could you do?
I can give them insulin and glucose.
Yeah.
And if I have some time and the patient is not that sick, I can start them on give them some like high molecular weight raisins, which will help in potassium exchange.
I mean, like a potassium binder of some sort.
Right.
Yeah.
Yeah.
So yeah, you could give calcium, insulin, fluids. Some people even have described giving albuterol, which can drive potassium intracellular. So just to review, sorry about this. I don't know if you can hear this really big banging noise behind me. I don't know what this is from. I assume it's the wind outside. So this is a demonstration of what happens to your ECG with elevations in your potassium level. So here we have a sort of top normal potassium, and we see that the T wave can start to peak, and at a higher level, the P wave will start to flatten, and the T wave is still very high, and the QRS is starting to widen a little. Then the P wave really becomes very flat, very hard to see. QT is lengthening, T wave is big, QRS is widening. Now we have profound widening of the QRS. This almost looks a little like the tracing I just showed you. At 9, we're really very wide, almost sinusoidal. And here we are basically on the verge of dying. So very high potassium. So initially you get depression of the ST segment, a diphasic T wave and a prominent U wave. But then eventually you start with the peak T wave, and then as the potassium level rises, the PR interval will lengthen. The P wave will also flatten. QRS will widen. The T wave remains peaked, and eventually you lose the P wave and you start developing what is sometimes referred to as a sinusoidal wave pattern. And so when you see this, obviously, the things you have described are all appropriate. And, again, in addition to what we talked about, you could give K-oxalate to lower the potassium, but K-oxalate would not be the first agent we would use to acutely get rid of the extracellular potassium. That's the danger in this setting. Any questions about that?
No,
Okay.
thank you.
Thank you. Okay. Right. This was a newborn who had open heart surgery on post-op day 7, and the astute fellow was reviewing the telemetry, and very early in the morning sent me this via text because of concern. So we'll see what people think. So let me see if is Molly on the line?
Yep.
Molly Marshall, hello.
Good morning.
Hello. So what do you think, Molly?
Do we know what the surgery was?
Yes, the surgery was an arterial switch operation with ASD PFO closure.
Okay. So first, in terms of looking if it's sinus or not, I'm having trouble seeing the P wave morphology. It looks like there's a little blip, but I'd rather, I'd want to see like an EKG to see that. But what's more striking is there's changes in QRS morphologies a little bit. The second and third beats are like what look like a more narrow complex. And then the remaining ones are wider.
Talking about these 2 beats versus some of these beats.
Yeah, and so I'd like to know if the kid's post-op EKG, if he had like a right bundle branch morphology or anything like that, just to know what his usual QRS looked like before we're seeing these alternating. And then also it looks like there's a little bit of ST elevation as well, which especially when thinking about an arterial switch, wanting to think about coronary perfusion.
Now, the thing about it is there any other possibility in this differential? Like, do you notice that the QRSs seem to change? In other words,
so
this
it could
beat
be
looks quite a bit different than, say, this one or this one. This sort of
Yeah.
wide thing seems to be occurring in almost in a different relationship to the sharp thing.
Yeah, so it almost looks like it could be if the kid's under like before this was if it showed a bundle branch morphology, if it's like if the narrow ones are like almost like a pseudo normalization beat of like a PVC coming in early, or if you're having like a competing rhythm there, especially where the beats look like there's like 2 peaks almost like on top of each other, and it looks a little like they're right next to each other, but almost even a little different as you march out through the strip.
So I put these calipers on here to sort of show that, and all of the calipers are exactly the same, just for the record. I think this is artifact. So
Gotcha.
So if you look, you can see that. So generally, you always want to try to, when you're doing calipers, take 2 or 3 beats, just because the error will be a little lower, a little easier to prove. But the bottom line is that this narrow QRS marches out exactly time throughout the beats. And this is some kind of artifact. I don't know if this is chest PT, or I'm not exactly sure what to make.
Mhm.
So a little curious because it's almost at exactly the same way
Yeah.
as the QRS, which is, I think, what's confusing about this tracing. But the thing that kind of, when I was asked to look at this, got me thinking was, here we have this wide thing before this sharp part, but here the wide thing is after the sharp part.
Mm-hmm.
And the relationship of the QRS, or the narrow part, and this wide thing seems to be changing throughout. So I think that they are almost at the same heart rate, or at the same rate, I should say, but they're not exactly the same rate. So I think this is just sinus rhythm at a rate of about 100,
Mm-hmm.
some kind of a weird artifact that's curious and concerning, but I'm pretty sure, based on the way these march out, that this is just sinus rhythm with artifact. So it's you always want to take out your calipers in these circumstances and see, this really does look quite a bit. If in your mind's eye you remove this initial portion, I think I could convince you that this looks an awful lot like this or this.
Yeah.
And I agree, I don't see the P wave very well before them, but again, that's always the nature of looking at telemetry, and you could kind of convince yourself that there's something that's kind of like a P wave before each QRS, but I agree, I don't know for sure. So, all right, so this is an interesting artifact, a harder than average artifact.
Any thoughts on the ST segments on that last one?
Well, again, I think that the STs are just, it's an interesting question. I think it's just some relationship of the artifact, because you see here on this beat, right, it seems to almost be getting higher over these, but this artifact, whatever it is, seems to be moving into the QRS more. And I think this is just, I think there's sort of like some kind of weird artifact that's on top of each of these beats, and as it moves closer to the QRS, the end of the artifact is sort of looks like an ST elevation. The fact that you don't see any ST elevation over here would be a little weird, to have ischemia here and not have it here. I'm not saying it couldn't happen, but it's not like the heart rate is faster here or here than here. If you saw like rate of 150 and then a rate of 100, you could say, well, there's more oxygen consumption, and maybe that's why there's ischemia. But I think it's all artifact, but it's not an easy artifact, this one, which is why I understand why the fellow was concerned appropriately.
Thank you.
Sure. So this is a 9-year-old with cardiomyopathy who has a ventricular assist device. And the question is, what is the diagnosis, and what should the management be? So why don't we ask Dr. Capon from our ICU cardiology team.
Good morning. Can you hear me, by the way, because I'm using the computer for the first time?
Yeah, we can hear you pretty well.
Awesome. So good morning. So we see here on this rhythm strip what appears to be the first beat on our left looks widened. And then from that, we see what appears to be a sinus beat with an upright P wave in 1, 2, and then, yeah, AVF as well. And then we see another what appears to be a sinus beat. And then it looks like we almost have widening of the QRS complex for 3 beats. And then again, we kind of go in and out of what appears to be sinus rhythm, and then some ventricular couplets or triplets. So I think in the setting of a patient with the VAD, this can sometimes happen when their fluid deplete, just in the setting of kind of suctioning from the VAD pump out and almost kind of tickling the ventricle, as we've said in the ICU in the past. So I would call this normal sinus with intermittent PVCs, what appears to be sometimes couplets and triplets in the setting of bad physiology. In terms of management, I would make sure that they were volume sufficient, and then re-look at my settings if the volume was optimized.
Okay, I agree completely with that analysis. Good. I mean, I think the important thing to remember is that, yes, I certainly agree with you 100%, Ivana, that you want to check the volume status, make sure that, why would the volume status matter?
So if you are underfilled, for example, if you're drawing out from your RV and you're underfilled, if you don't have sufficient volume in that ventricle, you are more likely to suction, let's say, the ventricular tissue itself, which could cause irritation and cause a ventricular ectopy.
That's right. So the cannula themselves can cause ectopy. And although you would always want to be aware and evaluate and treat the issue you're describing of having either too little or too much volume, most of the time patients are euvolemic with a VAD, especially when it's been in for a while. And there are times that, unfortunately, there's nothing we can do about it. Because the VAD is simply, I mean, it makes sense, right? It's tickling the ventricle. It's because it's literally, in a weird way, I'm surprised this doesn't happen with greater frequency in people with VADs. I guess the surgeons are very careful to make sure that the tip is as free in the ventricle as possible. But, you know, having a gigantic, 26 French catheter that's going through the free wall of the ventricle, two ventricles, I should say, it is not surprising, right, that you would have this, or one ventricle. So, yeah, you would make sure the volume status is adequate, that you're
Check
not
electrolyte.
filling. But
Check
I don't think,
electrolytes for anything else.
what's that?
You'd also just check electrolytes if you notice an increase in ectopy. Obviously, this patient's on a VAD, so he's likely hemodynamically stable, but make sure the VAD's functioning appropriately and all that. But I don't think there's much to do other than optimize the patient themselves.
Right. I mean, in theory, the patient could even go into VF and would potentially be okay because of the support of the VAD. Obviously, any contribution of the patient's output is useful and important. But in most VAD patients, right, the VAD is doing the majority of the work. And you can usually maintain cardiac output with just the VAD. But yeah, there's often nothing we can do about this. And, you guys have now seen in the last year, we've had quite a few VAD patients. And, it's every patient is different because the placement of the VAD is going to be slightly different. And then you have some patients who never are bothered by ectopy, and then other patients who we're dealing with it on a daily basis constantly. Based on the position. And yet, despite that, we virtually never clinically have a serious problem related to this ectopy. It's really more frightening to us than it is maybe clinically a problem. So, and yeah, we could check the electrolytes, and it's always the right thing to do. But truthfully, it's that very rare patient in whom the electrolytes are the issue. Occasionally, right, we have some patients whose magnesium level is pretty low, and it does seem temporarily that we replete the magnesium and the patient seems to get better. Occasionally, some hypokalemia we notice can sometimes be associated with something like this. But truthfully, the vast majority of the time, the electrolytes are not the etiology. This is just a mechanical problem of the cannula tickling the inside of the heart. Okay. All right. Forward here. So, this is an ECG from the website blogecg.com. I'm sure you all visit it often. And the question is, what is this rhythm that we're looking at here? And I don't know the right answer, by the way, but we could try to figure it out. So let's see here. Dr. Kalis, what do you think is going on here?
All right. So I do see what looks like a P wave for every QRS.
Yes, I agree.
And although the P wave has this like biphasic or this like kind of notched morphology, it is perhaps a bit wide. And the rate is irregular.
It's weird, right?
Yeah, so
but it is sort of grouped, right?
Yeah, it kind of seems like there's 2 beats and then like a little bit longer pause, and then 2 beats and then a longer pause. So, my initial thought was maybe a sinus arrhythmia, but it seems so, I would think the pattern would be a little bit different, like a more gradual
Yeah,
slowing and,
I agree with you on that.
getting it, faster and slower, a little bit more gradual.
Mhm.
And so, but then, the P morphology does kind of look the same, like instead of thinking of like a PAC or like a,
Right. I mean, the thing is, it's always hard with a single lead. I
yeah,
agree, right? You're basically saying this P wave and this P wave look kind of the same, right?
yeah.
But they may not be the same, and
Mhm.
one lead, anything can look the same. So I'll tell you what the eminent website blogecg.com thinks is a differential. So they theorize first that it could be sinus rhythm with atrial or junctional bigeminy. So basically every other beat is a PAC.
Okay.
Maybe a premature junctional beat with a sinus beat that's coming. That's a possibility. Could be sinus rhythm with atrial trigeminy, where every third beat is a PAC that's blocked and not conducted. But this doesn't seem likely because this P wave is pretty big, and I don't obviously see a P wave buried in here. So that's possible, but it seems unlikely. Could have some form of SA nodal block where basically you're in sinus rhythm and then the third P wave just doesn't come out of the sinus node. There's some kind of problem in the sinus node where you have 2 beats, a pause, 2 beats, a pause. That's possible, but it's extremely challenging to prove, but is certainly a possibility. Could have Mobitz 1 second-degree block with like 3-2 conduction. So, the theory behind this would be that you do see a little bit of maybe PR prolongation here in the second beat of each of these. I'm making this up a little bit, but this could be Mobitz 2 second-degree block where there is a third P wave that we don't see that's not conducting. So it's almost impossible to know. If we had a His catheter in place, we could figure this out pretty easily. But in the absence of that, it's very hard to know. But it's an unusual tracing, and just shows how it could be, sometimes these can have multiple etiologies.
And with the kind of like the widened notched P wave, would you think of maybe like a left atrial enlargement?
Well, yes, I mean, right, we know that this is like what they call a P mitrale, old-fashioned term for LA enlargement. So yes, it would be presumably like a P mitrale or a big LA. We don't use those terms so much anymore, but yes, it's certainly suggestive of there being, which is why a lot of these diagnoses where we're not seeing the third P wave seem less likely, right? Because we have a nice big juicy P wave as opposed to some cases like that first one I showed today where you could barely see the P wave and, we were struggling to see it. In this case, it's very obvious. So I think a lot of these ones where we're having a blocked PAC doesn't seem very likely since I don't actually see the PAC that's getting blocked. I see no QRS, but I don't see the insider here. So interesting tracing. Okay. This is a congenital heart patient who has a pacemaker. And whoops, I see here, Mahmoud's asking, would you take this patient to EP study if the rhythm was hemodynamically well tolerated? You're asking, Mahmoud, I assume, about this case. I think a lot of it would depend on how bad this is and how often and frequent we see this. This certainly would warrant some kind of telemetry or, ambulatory ECG monitoring. It might become more obvious. In other words, if I saw this one time over a 24-hour period, but the entire rest of the time the patient was conducting 100% of the time, I would be less worried about this. If I saw this a lot of the time, then I would probably start getting worried. And a lot of it how aggressively I would evaluate would also depend on the patient's scenario. How symptomatic is the patient? Is the patient a post-op congenital? So we know that there are patients who have late development of heart block following congenital heart surgery, and they are at risk for problems. I'm a co-author on a paper about 15 years ago on that. So yeah, I mean, that would be a scenario. If I saw this a lot on an ambulatory monitor, or if the patient was symptomatic with being tired or shortness of breath or things of that nature, yes, for sure, I would do some kind of more invasive evaluation. But I would first start by surface ambulatory monitoring, because oftentimes the answer can be ferreted out in that manner. Okay, so just getting back to this patient. So this is a patient who has congenital heart disease and came into the office for a pacemaker check. And so the question is, what's going on here? So why don't we ask Dr. Condon what she thinks is going on here?
Good morning.
Morning.
So if I'm looking at the pacing spikes. It looks like there are there's pacing spikes before the P and before the QRS.
I agree with that. Correct.
And
but there is something irregular going on here, right?
Yeah.
Sometimes it's useful to just look at the rhythm strip on the bottom.
Sure, yeah.
It makes it more obvious what's going on.
Yeah, so in the first beat, we have a P, a QRS, and a T. Second beat, same thing. And then in the third beat, it looks like there is there's a QRS complex that's different from the prior two. So maybe a PVC.
Yeah, it's a PVC.
Wider.
Right. It's kind of PVC. And then what's the pattern of the P? So if you had to describe it, let's make this 1996 Rob Pass Fellowship. You're on call and you have to tell Dr. Newberger, who's attending on, that you're worried about a patient. You have to describe the EKG because there is no cell phone ability to send a picture. So how would you describe this patient's EKG to the attending?
I
mean,
would
you
say
said it all right. So how would you sort of summarize what you just said?
It's a patient with a pacemaker who
Single or dual chamber?
Dual chamber.
Right. So dual chamber
pacemaker.
Who's AV paced.
AV paced, and who's having a PVC every third beat.
So what's the other term for PVC every third beat? I agree with that 100% with everything you've said, but what would be a fancier way to say a PVC every third beat?
Trigeminy, ventricular trigeminy.
Exactly. That's ventricular trigeminy. So that's AV pacing with ventricular trigeminy. So if I told you that this patient had, I'm now making this up. Let's say the patient has tetralogy of Fallot. And let's say this is one of Dr. Zadie's patients and is say a 27-year-old. What would you do for this patient? Patient feels fine, is just coming in, and you've never met this patient before, and they say to you, I have PVCs. And that's all you know. And I feel great. I'm working. I'm, doing well. How would you evaluate this patient? So, of course, you would check the pacemaker and determine that the pacemaker is working. Let's assume the pacemaker is working fine. There's actually no evidence on this tracing that the pacemaker is not working fine. There seems to be both atrial and ventricular capture. There's no undersensing. We're not seeing pacing during this QRS, which is important. So it's sensing properly, is to the best of our ability to know these things. Seems to be capturing well. Would there be any other testing you might recommend seeing this?
I think that I would want to make sure, I'd want to know when their last echo was, just to make sure that their function is okay.
Now, that's a good point, but what,
Oh, you mean
so you
electric
want to
is
know
okay?
both the LV and the RV, right? Because
Yeah, you
so
can
when we
get
see,
LV dysfunction.
right. So when we see PVCs in anybody, we get concerned, but particularly in a tetralogy patient,
Mhm.
right? We're always worried about the rare patient who has either VT or sudden cardiac arrest. And
Mhm.
so I agree, we would definitely want to get an echo because we would want to know, what is actually, we've talked about this before, but probably the single best predictor of having a cardiac arrest or VT or VF is actually LV dysfunction, which is not obviously intuitive in tetralogy, right? Which is an RV.
Mhm.
We think of it as an RV disease. But in most other human beings and also tetralogy patients, the LV is actually the best predictor. And studies have shown either an elevation in LV end-diastolic pressure above 12 or LV systolic dysfunction, both highly associated with bad outcomes. So you would definitely want to get an echo. Also, the RV, obviously, if you have bad RV function, that probably is bad too.
So
So you want an echo, and let's assume for the sake of conversation, the echo is basically normal. There's, mild to moderate PR, RV is and LV function are preserved.
I think that we would maybe consider a Holter.
Yeah, exactly.
To see what the burden of ectopy is.
That's exactly right. We would want to get a Holter in order to see not only what percentage of the PVCs, what percentage of the QRS complexes are PVCs, but you'd also want to know if there's any high-grade ectopy. And in this particular case, the patient had actually had a Holter by Dr. Zaidi just like a month prior that showed 5% PVCs. And they were all single PVCs. So that would be, the absence of symptoms, the preservation of function, basically not an especially wide QRS despite being paced.
That's true, yeah.
And asymptomatic with only 5% PVC burden. We would predict that this patient would be also, 26 and not 46, because the longer you are from the repair, the greater the chances of having ventricular arrhythmias. We would be, feeling reasonably good that the chances of a serious event are low in this patient.
Right.
So I was pleased when I saw this, that the patient told me that actually they had just had a Holter and they had 5% PVCs. And actually the patient told me that in the past they had more, and they were very pleased to see that the number had seemed to have gotten better for some reason. So, all right. I think with that, we'll stop. Any questions about this or anything else we've discussed today? All right. Thanks, guys.
Thanks so much.
Good day.
Thank you.
Thank you.
All righty. Be well. Bye-bye.